Morning, Ms. Newman.
The knee is one of the most complex joints in the body. Knee complaints are the second most common musculoskeletal symptom evaluated by the primary care physician. The anatomy of the knee joint consists of three bones, the femur, tibia, and patella, with three areas of articulation. Some of the unique features include menisci, intra and extra articular ligaments, and the patella itself. The menisci are fibrocartilaginous structures located between the tibiofemoral articulations. They increase stability and distribute contact forces on the articular cartilage. The important soft tissue structures of the knee include the four major ligaments, the anterior cruciate, posterior cruciate, medial and lateral collateral ligaments, the joint capsule, the medial and lateral menisci, the quadriceps tendon, and the patellar tendon. All of the bones and soft tissues of the knee are subject to injury. Common adult knee complaints in an office-based setting can include fractures, the most common being the tibial plateau and patellar fractures. But much more common are soft tissue injuries and overuse injuries. Common types of injuries are often caused by reproducible mechanisms of physical trauma or forces. Valgus strain causes damage to the medial collateral ligament. Abrupt non-contact deceleration or twisting and pivoting involving a valgus stress can tear the anterior cruciate ligament. The classic triad of injuries of medial collateral ligament, anterior cruciate ligament, and medial meniscal tears occurs with various combinations of the following forces and movements: valgus stress, pivoting, and/or hyperextension. The posterior translation of the tibia in relation to the femur can injure the posterior cruciate ligament, as might occur in a motor vehicle accident when the dashboard pushes the tibia posteriorly. Overuse injuries are often manifested as pain in the structure subject to repetitive stress. Examples include patellar tendinitis or jumper's knee from repetitive jumping, patellofemoral syndrome from repetitive flexion, and pre-patellar bursitis or housemaid's knee from repetitive kneeling. Obtaining a complete history is the first step in determining the cause of knee pain. Key elements include location and characterization of pain, mechanism of injury, sound of a pop at the time of injury, possibly indicating a ligamentous tear or fracture, immediate or delayed swelling, recent infections, ability to bear weight, locking sensation or instability such as subluxation, and any prior injuries to the joint. To assess non-traumatic, subacute, or chronic causes of knee pain, in addition to questions about location and characterization of pain, you should ask questions about fever, morning stiffness, pain after exercise, tick bites, infections including STDs such as gonorrhea, history of gout or psoriasis, and activities of chronic overuse.
All right, maybe you could step down and walk for me so I could see how you're walking.
Gait. Examine the patient's gait and weight-bearing abilities. This can help distinguish knee pathology from pain referred from the hip, lower back, or foot.
Okay, now I'd like you to squat down, just like this.
If clinically appropriate, then the patient can be asked to perform a duck walk. A duck walk requires an intact ligamentous system and a knee free of significant meniscal pathology, effusions, and bony abnormalities such as arthritis.
Any pain while you're doing that?
Yeah,
And where does it hurt?
right in here.
Right in there.
Thus, if a patient can duck walk, ligamentous instability, significant effusions, and meniscal tears are less likely. Next, observe the alignment of the knees. With the feet together, have the patient stand. Observe for a varus, bow-legged, or valgus, knock-kneed deformity. Such deformities can predispose the patient to osteoarthritis or indicate the presence of significant osteoarthritis. If there is a suspicion of quadriceps atrophy, consider measuring each thigh to confirm the observation. Before performing the examination of the knee, you should always examine the back, ipsilateral hip, and ankle.
Any pain in your knee when I move your hip?
No.
Next, examine the skin of the knee for any abnormalities including hematoma, rash including psoriasis, abrasions or lacerations, and cellulitis. Always examine both knees, beginning with the unaffected knee. This will reassure the patient and limit any apprehension about the examination. It will also establish a baseline by which to compare the affected knee. Using the back of the hand, assess for warmth as an indicator of inflammation, localized or global about the knee. With the knee at 90 degrees, palpate the knee, starting with the anterior structures. Start by placing the thumbs on the tibial tuberosity and move superiorly. As you move superiorly, palpate the patellar tendon and its insertion at the inferior pole of the patella. Pain in this area, especially in an athlete, might represent patellar tendinitis or jumper's knee. In a patient with a direct trauma to the patella and isolated patellar tenderness, an X-ray should be performed to rule out a fracture. Alternatively, in a patient with focal tenderness, erythema, warmth and swelling anterior to the patella, with a history of recurrent kneeling or of direct trauma, one would consider acute prepatellar bursitis or housemaid's knee, which may or may not be septic and may require aspiration or drainage.
Is this where it hurts in here?
Pain, swelling, and a palpable defect at the insertion of the quadriceps tendon into the superior aspect of the patella is suggestive of a quadriceps tendon rupture. This injury may be accompanied by a pop and loss of extensor strength. Next, return to the inferior pole of the patella and move medially to examine the medial joint line. Pain along the medial joint line might represent medial compartment osteoarthritis, medial collateral ligament injury, or a medial meniscal tear. Next, palpate the pes anserine bursa, located at the midpoint between the anterior aspect of the medial joint line and the tibial tuberosity, at the site of the insertion of the medial hamstrings. If tender, bursitis may be present. Next, examine the lateral joint line for tenderness, which can be caused by lateral compartment osteoarthritis, injury to the lateral collateral ligament, or a lateral meniscal tear. Focal pain at the lateral femoral condyle is suggestive of iliotibial or IT band syndrome. Next, palpate the popliteal fossa. One might identify a fluid-filled mass in the popliteal fossa called a Baker's cyst, which often accompanies osteoarthritis. However, any mass should be evaluated with ultrasound, MRI, or biopsy. A large intra-articular effusion may be visually detectable by the absence of the normal indentations on peripatellar grooves on either side of the patella. Two maneuvers can help confirm the presence of an intra-articular effusion. With the knee extended, use the non-dominant hand to squeeze the intra-articular fluid from the suprapatellar region into the space between the patella and femur. With the dominant hand, exert pressure superiorly from the tibia while using your index finger to push the patella against the patellar femoral groove. When an effusion is present, you can ballot the patella. A second method to assess for an effusion can also be performed with the knee in extension. Gently milk the fluid into the suprapatellar pouch by moving your hand proximally along the medial aspect of the patella. Next, milk or compress the fluid from the suprapatellar pouch to the medial knee by moving your hand from the superior lateral region to the inferior lateral region. If there is an effusion present, when compressing the lateral regions, a bulge will appear medial to the patella in the areas that are naturally concave. Comparison with the unaffected knee is essential. If an effusion is present, arthrocentesis may be necessary for diagnostic and therapeutic reasons. Both active and passive range of motion of the knee should be tested. The normal range of extension is 0 to -10 degrees, and the normal range of flexion is 130 to 150 degrees. The location and movement of the patella should be noted, watching for any signs of abnormal tracking, crepitus, or pain. Retropatellar pain and crepitus while compressing the patella against the trochlea during active extension can indicate patellofemoral syndrome or patellofemoral arthritis. Injury to the medial collateral ligament, MCL, or lateral collateral ligament, LCL, typically involves direct trauma to the contralateral side of the knee. To assess the medial collateral ligament, apply valgus stress to the knee. With the knee flexed at 25 degrees, place one hand on the outer aspect of the knee, applying medial pressure, and the other hand on the inner aspect of the distal tibia, applying lateral pressure. Testing for tenderness or laxity along the MCL.
Does this bother you?
Yes, a little bit.
Similarly, the lateral collateral ligament can be tested by applying lateral pressure to the inner knee and medial pressure to the outer ankle or lower leg, causing varus stress to the knee. Instability with these maneuvers indicates a tear to the ligament or sprain. The anterior drawer and Lockman tests provide information about the integrity of the anterior cruciate ligament, or ACL. For the anterior drawer test, the patient should be supine with the knee flexed to 90 degrees and foot flat on the table. Stabilize the foot by sitting on the end of the foot. Place the thumbs on the tibial plateau and the fingers around the calf, relaxing the hamstrings. Pull forward to test the ACL. An intact ACL should abruptly stop the anterior motion of the tibia with a solid endpoint. The affected and unaffected legs should have similar degrees of anterior translation. The Lockman test is a more sensitive and specific test for assessment of the ACL. In this maneuver, the patient is supine and asked to relax the hamstrings. Use one hand to stabilize the femur while placing the knee at 30 degrees of flexion. The other hand grasps the proximal tibia and briskly pulls the tibia forward. If there is more than 6 to 8 millimeters of laxity, more laxity than the unaffected knee, or a soft endpoint, the ACL may be torn. If you are unable to firmly grasp and stabilize the femur, you can modify the Lockman maneuver by placing your knee under the patient's knee, firmly pressing down on the distal femur with your hand, while pulling anteriorly with the tibia with your other hand. To test the integrity of the posterior cruciate ligament, or PCL, perform the posterior drawer test. Again, the patient should be supine and the knee flexed to 90 degrees. The foot should be flat on the table. Stabilize the foot by sitting on the end of the foot, placing the thumbs on the tibial tubercle and the fingers around the calf. Briskly push the tibia posteriorly to test the posterior cruciate ligament. If the PCL is intact, there should be a solid endpoint and little posterior translation of the tibia. Patients with meniscal injuries may report clicking, catching, or locking of the knee and frequently have an effusion of delayed onset, presenting hours or even days after the injury. In addition to joint line tenderness, there are 2 physical exam maneuvers to assess for possible meniscal tears. In the McMurray test, the patient is supine. One hand is placed around the knee with fingers and thumb on the medial and lateral joint lines. Grasp the patient's heel and externally rotate the tibia while the other hand applies valgus stress at the knee during passive flexion and extension to test the medial meniscus. The maneuver is repeated when applying internal rotation and varus stress to test the lateral meniscus. Clicking, catching, or popping at the joint line during early or mid-extension may indicate a meniscal tear.
Ms. Newman, if you could lie on your stomach now.
In the Apley compression or grind test, the patient lies prone and the knee is flexed to 90 degrees. Stabilize the thigh by placing your knee or hand firmly onto the patient's posterior thigh. Grasp the foot and apply a downward compressive force while internally and externally rotating the tibia. Pain on compression is considered positive for a meniscal tear. Suspicion of a meniscal tear should prompt a careful assessment of the anterior cruciate ligament, as injuries to these 2 structures often occur together. In summary, a thorough history and physical exam are the first steps in the evaluation of knee pain. These help to establish an accurate diagnosis, after which decisions about imaging studies, X-rays, MRI, or ultrasound, treatment, and referral to specialists can be made.